Thank you so much, Rick. I greatly appreciate that, and it's an honor to be with everyone today. I want to go through some general principles of dual diagnosis, and by dual diagnosis in the mental health world, we often mean substance use and mental illness, but in our dual diagnosis, we're referring to mental illness and intellectual disability, and I will use the abbreviation ID throughout the presentation. Next slide, please. So let's be clear on our definitions before we get started. So mental illness and intellectual disability are two different conditions, but individuals who have ID are more vulnerable to mental illness. So we often see that they co-occur. The official definitions are on this slide. So the definition for mental illness, this is straight from the DSM-5. This is the Diagnostic and Statistical Manual, 5th edition, and mental illness is a disorder of memory, perception, judgment, cognition, or affect. And intellectual disability is a constellation of IQ less than 70, difficulties with adaptive skills, and onset prior to age 18. I think it's also important to note that in Ohio, individuals can still link with local county boards of DD up until the 22nd birthday. And so when I'm seeing a family or a patient who is a teenager or in early 20s, I will encourage them, if they are not already linked to their county board of DD, to do so before that 22nd birthday and to go through that eligibility assessment to link, even if they're not interested or in need of resources immediately, they may be down the road. And so that linkage is incredibly critical. Next slide, please. So this is the formulation. Back in 1977, a bit of history, Dr. Engel described the biopsychosocial formulation. And this is something that we learned in training and to use with each patient that we interface with, to look at that individual with all the information possible in those three categories: biological, psychological, and social. And I realized that when working with individuals who have co-occurring issues or intellectual disability and mental health conditions, that it's important to add that developmental piece. So this is a complete gathering of information. We want to interview the patient directly, and we also want to interview interested others, family members, caregivers, SSAs, DSPs, review of all clinical records. This can be extensive, certainly, but really valuable. And I noticed that when I take the time to review all of the records, there are things that will pop and will help us get from point A to point B much more quickly. We don't want to repeat medication trials, for example, that were not successful in the past. On the other hand, if we have these long lists of medications that are in that category of they didn't work or they were failed trials, we want to take a closer look at those and make sure that they were adequate trials. We also want to talk to collaborating agencies, and of course, we want to add that developmental piece. We want to understand the individual and their specific developmental needs in a meaningful way. And of course, we want to use trauma-informed care and trauma-informed approaches as universal precaution. Next slide, please. We're going to actually go through these 4 categories in a little bit more detail. From the biological standpoint, we want demographic data. So we want to describe the patient. We want to characterize the patient and all of those important and critical pieces of information. So it's a 17-year-old male with history of any psychiatric diagnoses and medical diagnoses that we're aware of at the time of assessment. We want to take into consideration important family history. Maybe the individual has a mother who's been diagnosed with bipolar disorder. That will certainly be important information to consider. If there are medication trials, we have second opinion assessments that are available through the CCOE, and it's really critical for us to have a list of medications that have been tried in the past, anything specific that happened with those medications, important pieces of information, adverse drug reactions, allergies, etc. And of course, if there's any substances used in the past or acutely or currently, we want that information as well. Next slide. So this is from a study at the University of Colorado where this was a clinic setting where individuals with ID were seen and assessed and treated, and 85% of them had at least one untreated, undertreated, or undiagnosed medical condition. So that's really important. And actually one of the reasons why I was drawn to treat this patient population. I had several patients on the unit at Twin Valley Behavioral Health Care that I was providing care for, and they had limited expressive language skills. And after doing thorough physical exams with our internal medicine physician, we were able to reveal undertreated medical conditions, often painful conditions that were easily treated and with reversible symptoms. Also, it's important to know that medical comorbidity or medical conditions are more prevalent in every single organ system. So that's central nervous system and lungs, heart, GI. And so it's really common for individuals with MIID to also experience neurologic and medical conditions. Most of us work in clinical settings where we have restrictions on care. We have limited office visits, limited frequency, limited length of visits, number of minutes. We're incredibly fortunate to be linked with the Ohio Department of Developmental Disabilities and OMOS as well. And this allows us longer appointments, both at the time of intake as well as during the follow-up appointments. We've seen and inherited medication regimens that certainly could be described as polypharmacy, medications being used in ways they were not intended, in unsafe ways, and certainly with abbreviated monitoring protocols. So often we'll have patients or families come in and say, well, we can't get lab work, we can't have blood drawn. It's really important for us to have more objective data because sometimes we will have less subjective data. If there's decrease in self-report, for example, we want to have an extended lab panel and make sure that the individual is linked with a primary care physician who is actually providing thorough physical exams and seeing the patient serially. Next slide, please. So just a few words about medications because these fall in that biological category. We want to start low and go slow. These are principles that we would recommend for the pediatric population as well as the geriatric population. We don't have specific best practices or evidence-based medicine principles just for the ID patient population, but we do have them for the general population. And we certainly can apply those in meaningful ways and be thoughtful about prescribing. Benzodiazepines, these are the medications such as Ativan, Xanax, Klonopin. And so these are the medications that we want to use extra caution with. Some individuals will have a disinhibition or an opposite reaction. So these medications will typically cause lower anxiety. They'll help an individual be calm. And so some individuals with ID will experience the opposite of that. So they may become disinhibited or agitated. We want to ask specific questions at the time of intake. And so if this isn't mentioned, then I'll typically throw in a question or two about, has this individual been given medications prior to procedures, for example, dental procedures, surgical procedures, imaging, etc. And we also want to keep in mind that individuals with ID are more vulnerable to side effects, and this includes our metabolic side effects. The metabolic side effects include elevated blood sugar, elevated cholesterol, weight gain, etc. And EPS or extrapyramidal side effects. These can present as head and neck abnormalities, muscle spasms, tremors, for example, or tremors in the hands or upper extremities. We want to be not only looking for these and use caution to prevent these, but we want to be using some kind of screening tool that's universal and standardized and use that more frequently than you would in the general population. Timelines are incredibly helpful, and when we do second opinion assessments or when we're doing an intake for the first time, we have teams all around the state that will give us these timelines of medications that have been prescribed over the individual's psychiatric treatment in the past. And so many times things will just pop from this information. You'll realize that, oh, serotonin medicines like Prozac or Lexapro, those actually will cause agitation. That's good to note in those medical records so that we can make more informed decisions moving forward. Beta blockers, and by the way, beta blockers, lithium, and clozapine, those three categories or medications have the most literature to back them to decrease aggression and to keep people out of hospitals. Individuals with traumatic brain injuries, for example, They will often present with mental health issues after that brain injury, and so we want to be watching for those changes. And also if they historically or prior to the brain injury had some kind of depression or anxiety, for example, we want to also keep close monitoring for worsening of that condition. We also want to think about other agents as opposed to jumping to maybe a second mood stabilizer or a second antipsychotic. If the individual has symptoms in the category of irritability or attention span issues, difficulty concentrating or completing tasks or impulsivity, we want to keep in mind the use of alpha agonists like clonidine and guanfacine, and there are others certainly in this category. Next slide, please. These are a few other notes about medications for this biological category. Dysphagia is very common in patients with ID. I always want to ask questions about swallowing, any swallowing problems, any difficulties with digestion, for example. That helps open that door to find out about digestion, upper GI, upper respiratory system, anything that we need to be aware of. And they'll often just ask the patient, do you have difficulty or any problem swallowing pills? And that's something that's very uncomfortable and people typically remember and will offer to you. The 3 p.m. is one of the my go-tos, because if a patient is taking a medication in the morning and at bedtime, for example, and they're having difficulty in the late afternoon or evening, I'll often just move the bedtime medicine, depending on how sedating it is, of course, to that 3 p.m. or at a smaller dose at 3 or 4 p.m. That's transition time. So a lot of individuals are going from more structured or routinized settings into a less structured environment. Most of us have less structured home environments, and it can be a time where there's a lot more stimulation or less direction or a lack of a schedule. And so a lot of individuals can have difficulty during that time. If a patient's not taking their medication or they're refusing meds, non-adherence, that's something that I want to own as a prescriber. And so I want to bring that up in the appointment. Is there something that you don't like about that medicine? Does it taste bad? Does it make you tired? Does it make you run to the restroom? Is it expensive? Is it hard to get from the insurance company? So let's really delve into that and figure out why is there non-adherence, and make a change so that the patient is comfortable with that medication. We talked a little about polypharmacy. We want to make sure that we're using a team, where we are part of a team and we're not focusing on the medications as this is going to, there's going to be some miracle medication regimen. There'll certainly be an important part of the treatment of many mental health conditions, but there's also so many other things we can offer patients. For example, psychotherapy, and we'll get into some other long lists of things in our social category. We also want to always be cognizant of seizure threshold. So even if the patient doesn't have a history of having had a seizure in the past, I use extra caution with all of the medications. And there's a long list of medications that affect seizure threshold, but some of the more common ones we might be prescribing or have patients prescribed by other professionals include antihistamines, anticholinergics, phenothiazines, Wellbutrin, clozapine. And it doesn't mean that we can't prescribe these medications or that we should not, but we should use some extra caution and ask some extra questions along the lines of seizure threshold and past seizure history. Next slide, please. So the second category is the psychological category. So this, I know talk to the patient sounds very simplistic, but often I have patients in my office that will come in and don't expect me to talk to them directly. They've had other experiences or they have a collateral data source accompanying them to the appointment. They may just expect the clinician to talk directly to the collateral data source and not include them in the conversation. And so we always want to make sure we include the patient in the conversation, and we talk to the patient first and we address that individual. We want to keep in mind that expressive language skills, or the language that an individual uses to speak to others, and receptive skills, the language that they interpret and understand when others speak, can be developed at different levels. So if someone has very limited expressive language speech, it does not mean that they don't understand everything that's being said in the room. And I often find that I find that my patients understand virtually everything that's said in the room. And so we don't want to make or put those two in the same category. We want to be respectful and talk to the patient in a way, find a way to communicate effectively with that patient. And I think that with practice and seeing a lot of patients, we can always make that happen and be successful. We want to set the stage when the appointment begins. We want to make sure everyone has been identified and their role in the team. We also want to be respectful that the patient is seeing a clinician, and in my case, seeing a psychiatrist. So we want to make sure that if there are multiple people in the room, do we need everyone in that room, and is that the patient's preference? There are other ways to communicate important information from different team members and different collateral data sources. We want to be respectful of that. One of the most common fears that I find in my patients is that they wonder if they're going to get a shot. And so I usually bring that up, especially if it's an intake and it's the first time they've been in a clinic setting. Then I want to bring that up and let them know what's going to happen in the appointment and what's not going to happen in the appointment to alleviate any fears. If I'm going to be asking questions, then I also want to give the patient choices about if I bring up a question or a topic and you don't want us to discuss that, then please give me a sign or let me know and we can move on to something else. And if there's miscommunication, I want to own that as the clinician in the room. And I want to say, I don't think I asked that question correctly. Let me try again. So we want to be honest if we don't understand communication, and so that everyone's on the same page. And certainly summarize at the end. That's really helpful. So this is what we talked about today. These are the recommendations that we made. How do you feel about that? What are your thoughts about the recommendations for today? Next slide. When an individual has communication issues or difficulties, we want to keep in mind that anywhere from 60 to 80% of our communication is nonverbal. This goes for everyone in the general population. So there are lots of pieces of information that we can pick up without words. And this is a list of some of those. And we could probably make 5 or 6 slides full of things, but you want to be attentive and be observing relatedness in personal space. And does the individual feel comfortable with the familiar others in the room? How are they responding to that individual? What's the attention span, impulsivity, activity level? Are there repetitive behaviors or movements? Are there stereotypic behaviors? And we want to make note of those. Next slide. I want to go into some detail about question formats. This is one of my favorite areas of interviewing and communication. And so we want to use caution with certain question formats. So the yes/no questions, we may want to use some cross-questioning techniques, for example. So if someone is saying yes to everything, this could be a pattern that was developed at a different point in time when answering yes to everything or answering no to everything kept them safe or served a purpose, was functional for them to some degree. So cross-questioning means if someone says, if I say, are you having trouble sleeping? And they say yes, then I might want to say, are you having any, are you sleeping well? So I'm gonna question in a different way so that the answer should be different, and then we can sort of verify the accuracy of that. You can also do item reversal. The same thing with either or multiple choice questions. It's really, it's difficult for an individual if they have memory issues. If you say A or B or C, for example, then it's more likely you'll get C as the answer because that's the last thing that was said and that's an immediate memory. So you want to note serial position effects. So if I ask A or B or C, I might want to ask B or C or A the next time to check out that answer. So double-barreled questions are sort of tempting when you're time limited and you have to fill out a form or document in an electronic health record system, but it's very low yield in real life. And so we want to break questions apart and ask one question at a time. Long multiple questions are also very low yield. When people are in a hurry and you're trying to check boxes on a form, it may be tempting, but it's not, it will not be useful in the conversation. So we want to break these apart and ask one question at a time. Next slide, please. Thank you. So we also want to use time anchors. This is really important and it works really well. So if you're asking a question about a specific topic, you can tie it to something that matters to the patient. So it's a birthday or it's a holiday, maybe it's a weekly bowling night pre-COVID. So significant life events that tie the patient back to a specific place and time. Who, what, or where questions are going to be higher yield than when, how, or why questions. Individuals who want to please you or who want you to like them may answer questions along the lines of the answer or the response that they think you want. And so we want to check that out too, maybe do some cross-questioning there. A lot of individuals with ID grew up and were told in many circumstances, ignore that or don't cry, specifically if they were teased or taunted or marginalized somehow in a school setting or work setting, et cetera, or in a home setting for that matter. So the message that society or our communities have sent to some of our individuals, unfortunately, is ignore your emotions or don't talk about your emotions. We don't need to talk about that, ignore it and move on, or don't express your emotions. And so we really want to use some trauma-informed approaches and let people know that emotions are not problems, emotions are signals and should be talked about. And there are healthy ways to do that. Next slide. Okay, so it's a myth that I can't get good information from an individual with MIID. And why is that? Well, it's actually difficult for any of us to recant a situation that happened a week ago or a month ago when we're sitting in an appointment. So there are certain things we can do to help out with that. And we want to try direct open-ended questions. I don't avoid open-ended questions at all. I use these all the time, but I may direct someone to a time and place. So when you were at the movie theater last weekend and you looked in your wallet, what was missing? That's still open-ended, but I've taken an individual to a specific place and time to help get the answer. Next slide, please. So sub-localizations are this interesting phenomena where an individual will be practicing what they're going to deliver or response before they actually say it. It may take longer for an individual with cognitive issues to develop that response. And so it may look like they're stalling, or it may look like they're experiencing hallucinations, for example. We want to be very careful when we're talking to familiar people. If you're talking to your significant other, your partner, a sibling, a good friend, you probably will immediately respond, and there's not a lot of this sub-vocalization going on. But if you're talking to an unfamiliar person or an acquaintance, or if you're in a job interview, you're probably going to practice this quickly before you respond. And so those are sub-vocalizations, and this may be, it may take a longer period of time for an individual with ID. Next slide, please. So the saliency it's also along the lines of this important event that means something to the individual. So instead of asking questions that are important to me in filling out a form, I want to ask questions that have emotional strength or pull to the individual, so that it will be more important for them and they'll be able to retrieve information much more quickly. Next slide, please. So what works? Summarizing, clarifying, recapping, and paraphrasing. These all work really well. So if you think you've understood what the patient is communicating, we want to feed it back to them and summarize or clarify. And if you have an alliance with the patient, they'll quickly jump in and let you know if you didn't get it correctly. Next slide, please. So the key to success in the social realm is really looking at the individual. If it's transition age, are we looking at residential changes, educational changes, a change to programming or employment, peers, siblings? Does the individual have control over as many aspects of their life as they can? Are there renewed grief or loss issues for the patient or for parents or for caregivers as you move through phases of life? Or as an individual watches a sibling leave for college or get engaged or have a boyfriend, those kinds of things. Next slide, please. And I think that we talked a lot about this, just keeping in mind that structure and routine can be really important and can keep anxiety levels lower. And I always ask myself, does this individual have an inner circle? So who do they go to when bad things happen, or when they've experienced trauma, or when they need to talk? And I have amazing parents that I work with, and siblings and guardians. And so if I have a patient that doesn't have that parent in place, for example, or that important person, then I talk to the team openly about who is the inner circle for this individual and how can we help build that inner circle for them if needed. Next slide, please. And so these are also lots of other interventions to consider in addition to medical treatment and medications, and the list goes on and on. This is obviously abbreviated. There are many more things we can offer to individuals, but we want to be part of a team, a multidisciplinary team, as well as an interdisciplinary team. Next slide, please. And then the last key to success for me is really developmental. I want to view issues from the perspective of the patient. So I do a lot of reading in the area of developmental stages and the area or the function of their life, relationship issues. And I also tell my patients that this is your appointment. And so I want them to own that. I want them to let me know how they want to spend that time, if they have questions, certain specific topics, and they can bring a Post-it note with them or a list, for example. And they can really use that time in a way that they choose and where they have control over that. Next slide, please. So this is just to summarize, when should I get mental health involved if you're working with a person with ID? These are just some general guidelines that hopefully will be helpful. Has there been a significant life stressor? Has the individual actually made threats or attempts to harm themselves or others? Are they able to care for themselves and their basic needs? Have they lost touch with reality? So are we suspecting that there may be auditory or visual hallucinations, for example, or delusional thinking? And are they patched into services, but we have questions or concerns about medication side effects or recurrence of symptoms, etc. Next slide, please. So these are signs that the diagnosis is incorrect and I need to go back to the drawing board. If someone's not getting well, if I'm using more than one med in one category, or if I'm tempted to, then I want to go back and check the diagnosis and make sure I didn't miss anything and talk to team members. Are there residual symptoms and signs despite the fact that we're prescribing? We want to look at the individual as we would an individual from the general population. Would we expect to have residual symptoms and expect that patient to live with those symptoms? And if there are toxic dosages or, of course, presence of side effects. And then summary slide, next, thank you. ID does not protect one from mental illness, that's for certain. The statistics are higher in individuals with ID. And individuals with ID also they tend to be more vulnerable to side effects of medication, so we want to use extra caution in prescribing. We tend to overdiagnose psychotic disorders and we tend to underdiagnose anxiety and depressive disorders. Everyone should be trauma informed, and it's certainly a myth that individuals with ID can't benefit from the full range of mental health services, including psychotherapy, including state-of-the-art medication regimens, trauma-informed approaches, OT, PT, great advocates, etc. So that's my summary slide. Thank you so much for your time and attention. Appreciate that.